Next, I'd like to welcome Dr. Anandi Sheth. Dr. Sheth is an Associate Professor of Medicine, Division of Infectious Diseases at Emory University School of Medicine. She also serves as Associate Director for the Emory Center for AIDS Research, CFAR, Clinical Core. Dr. Sheth is board certified in internal medicine and infectious disease. She received her medical degree and completed her internship and residency at Johns Hopkins University School of Medicine. She completed a fellowship in infectious diseases at the Emory University School of Medicine. Please welcome Dr. Anandi Sheth as she presents an update on sexually transmitted infections.
Good morning. I'm Anandi Sheth. I'm an associate professor in the Department of Medicine and Division of Infectious Diseases at Emory University in Atlanta, and an infectious disease physician at the Grady Infectious Diseases program. I'll be speaking with you today on sexually transmitted infections with a 2021 update. These are the objectives. First, to identify recent trends in sexually transmitted infections, including emerging infections. Second, explain best practices on screening and diagnostic assessments of sexually transmitted infections. And third, summarize current guideline-based management of commonly seen sexually transmitted infections using the recently updated 2021 CDC guidelines. And so I do want to alert everyone to these updates. So the last version of the CDC's guidelines were from 2015. And as of just a few weeks ago, they were updated to the 2021 STI treatment guidelines. You can find a lot of information on the CDC website, so please do check those if you have interest after this lecture. So just to give an overview, STIs are highly prevalent. They have increasing incidence. They've been consistently increasing for 6 consecutive years, and you can see data here on the right from 2019 showing sustained increases in chlamydia, gonorrhea, and syphilis infections, including cases of syphilis among newborns. Anyone can be affected by an STI, anyone who's sexually active, but much of the increase has been seen in younger people, gay and bisexual men, pregnant people, and individuals from racial and ethnic minority groups. STIs are particularly challenging because many are asymptomatic, they may be recurrent or persistent, and for many infections, there's increasing antibiotic resistance. But notably, many STIs are associated with numerous adverse health outcomes, and these include increased risk of HIV acquisition, infertility, and other pregnancy and infant complications. So the rest of this talk will be based on a series of cases, so I'll go ahead and get started with the first case. This is a 20-year-old woman who presents for IUD removal due to bleeding and weight gain. She has no other associated symptoms at this visit. She reports 4 male sexual partners in the last year, uses condoms sometimes, and has no history of STIs, but reported last being tested about 18 months ago. Her speculum exam was normal, and the IUD was removed without difficulty. So is STI screening indicated for this patient? These are the updated CDC screening guidelines for sexually active persons, and I'll focus on those for women, but across this slide, which is available for your reference, those changes from the 2021 guidelines are noted in red. So for gonorrhea and chlamydia for women, annual screening is recommended for women under 25, and screening for women 25 and older is risk-based. Similarly, for Trichomonas, screening at all age groups is risk or prevalence-based. For syphilis, screening is also risk-based, but for all pregnant women. For HIV, all adults or all individuals ages 13 to 64 are recommended to have opt-out HIV testing. Testing is also recommended during pregnancy and in the case of a diagnosis of another STI. And for hepatitis B, screening is recommended risk-based as well as during pregnancy. And new for hepatitis C, screening is now recommended once for all adults and is also during pregnancy. So back to this case, remember this is a 20-year-old woman with no STI symptoms. She was tested per these guidelines, was negative for HIV, syphilis, hepatitis C, as well as for gonorrhea, chlamydia, and trich. However, she was seen for a research study visit 2 weeks later and also continued to have no symptoms. At that time, as part of the study, her vaginal swab was negative for gonorrhea, chlamydia, and trich, but she had a rectal swab and an oral swab that was positive for gonorrhea and negative for chlamydia by NAT. So for this patient, was extragenital testing indicated? And so before I go into specifics about extragenital testing, I do want to remind you all of a minimum STI risk assessment, which can be summarized with the 5 Ps. You can remember from the previous slide that screening recommendations for many of the STIs are risk-based, but in order to determine if risk-based screening is necessary, an in-depth sexual history is required to understand a participant's risk. And this involves getting information about a patient's partners, practices, protection from STIs, past history of STIs, and prevention of pregnancy. And specific to practices and related to extragenital testing, it's important to ask a patient what kind of sexual contact they're having, whether it's genital, anal, oral, or multiple. And so this is what the 2021 guidelines says about extragenital testing in women. So for men who have sex with men, screening is actually recommended at all sites of sexual contact, including extragenital sites, and you can see that from the previous slide that I shared. For women, the guidelines state that rectal chlamydia and oral and rectal gonorrhea testing can be considered in women based on reported sexual behaviors and exposure through shared clinical decision between the patient and provider. And so I would like to present the case to you for considering extragenital testing in female patients. So both men and women commonly report oral and anal sex, so it is not uncommon, even if you don't elicit the information, to encounter a patient who's had oral and anal exposure. In men who have sex with men, the majority of asymptomatic gonorrhea and chlamydia infections are actually rectal. This is 50 to 80% of infections are rectal, or oral, 20 to 40%. And notably, simultaneous positivity with those sites and genital positivity is rare. And so the majority of infections would be missed in that population if extragenital testing was not performed. In women without extragenital testing, about 15 to 30% of gonorrhea and chlamydia infections are missed based on data from several different sites, suggesting that testing at sites of exposure may be indicated for women. And to note, self-performed swabs, meaning rectal, vaginal, and oral self-performed swabs, are well accepted, and the results are concordant with provider-collected swabs, so this is an option for screening for patients. And finally, testing via nucleic acid amplification testing, or NAT, for gonorrhea and chlamydia is FDA approved now at extragenital sites. So I wanted to share these data with you just to provide the case for at least considering extragenital testing, including in your female patients. So just to continue on this case, so again, now this is a 20-year-old female with no STI symptoms that is positive for oral and rectal gonorrhea. What is the preferred treatment? A, ceftriaxone 250 milligrams IM plus azithro 1 gram PO times 1. B, ceftriaxone 250 plus doxycycline 100 milligrams PO VID for 7 days. C, cefixime 800 milligrams PO times 1. D, ceftriaxone 500 milligrams IM times 1. Or E, I need a little more information. And so the answer here is actually D, ceftriaxone 500 milligrams IM times 1, but for reasons I'll get into in the next slide, E, I need more information, is also correct. And so what is the recommended treatment for gonorrhea? So remember that in the 2015 CDC guidelines, the recommended treatment was dual therapy with ceftriaxone and azithromycin, even if chlamydia is ruled out. And what I want you to do is actually completely forget that and move on to the 2021 CDC guidelines, which now recommend ceftriaxone 500 milligrams IM times 1, so single medication, but at a higher dose for treatment of gonorrhea. And notably, for patients who are greater than 150 kilograms, then ceftriaxone 1 gram IM times 1 should be used. And this is why needing more information about the weight is also a correct answer for this patient. And these revised guidelines were published in the MMWR back in December of 2020. And so again, just to reiterate, for treatment of gonorrhea infections, we recommend, CDC recommends ceftriaxone 500 milligrams IM and 1 gram if the weight is greater than 150, and combination therapy for gonorrhea is no longer recommended. However, if you haven't already tested for chlamydia, or chlamydia is not included at the time that you're treating for gonorrhea, then doxycycline should be added, and I'll come back to this point later. There are a few alternative regimens that are listed here, but notably, none of these alternative regimens are recommended for oral gonorrhea. It's also recommended to test sexual partners within 60 days, and also to consider expedited partner treatment, and this can be done using cefixime plus or minus doxycycline with the same criteria above. Testing and treatment of sexual partners dramatically reduces risk of reinfection for both gonorrhea and chlamydia. And so why did the guidelines change? So there were a number of different reasons. The first is shown by the bar graphs here, which demonstrate prevalence of azithromycin and ceftriaxone resistance among both men who have sex with men in red and men who have sex with women only in blue over time from 2010 to 2019. And you can see that resistance to azithromycin among gonorrhea urethral isolates is steadily increasing in both populations since 2010, whereas resistance to ceftriaxone, which started off as being uncommon, is actually going down. The second reason is for antibiotic stewardship. There is a lot of consequences of azithromycin overuse, and especially when more isolates are becoming resistant, it would be favored to not use azithromycin, both from a resistance standpoint and to preserve azithromycin for other pathogens. And then finally, our pharmacokinetic reasons. So higher doses have been recommended for treatment of gonorrhea because it's found that for some patients or in some body sites, the previous dosing of ceftriaxone does not get to the place where the gonorrhea needs to be treated in a sufficient manner. And so this higher dose, including a weight-based dosing for those that have a higher weight, is now recommended. And so are there any specific recommendations related to pharyngeal gonorrhea? So actually, there is the same recommended treatment for gonorrhea infection at all sites, which makes it easy to remember. But of note, pharyngeal gonorrhea is more difficult to eradicate, and there is an increased risk of resistance due to reassortment between Neisseria gonorrhea in the mouth and other oral Neisseria species. And so for this reason, for pharyngeal infection, the only option is ceftriaxone, as I mentioned before. And new in 2021, for patients with pharyngeal gonorrhea, a test of cure is recommended 7 to 14 days after treatment. If your patient has pharyngeal gonorrhea and has a beta-lactam allergy, it's important to thoroughly review the reaction and determine if cross-reactivity is likely. And for many patients, this process can allow for safe administration of ceftriaxone. If a patient reports true anaphylaxis or Stevens-Johnson syndrome with ceftriaxone, then an itis specialist needs to be consulted. Gonorrhea treatment failure is usually due to reinfection and not due to resistance. However, if there is a concern for resistance, which is a particular concern for pharyngeal gonorrhea, it's important to also send a culture, not just nucleic acid amplification test, and also report to the local health department. And this is because the culture is the only way to allow for resistance testing to be done. So moving on to case 2. This is a 20-year-old female who presents for oral contraception continuation and complains of thick vaginal discharge with mild intermittent pelvic pain. She reports a new male sexual partner 10 days ago. On exam, there's pain with speculum insertion, and there is thick yellow discharge as well as fibril cervix. Wet prep shows many leukocytes. And so which of the following is the preferred treatment? Again, this is similar to the previous. A, ceftriaxone 250 milligrams IM times 1 plus azithromycin 1 gram PO times 1. B, ceftriaxone 500 plus azithromycin 1 gram. C, cefixime 800 plus doxycycline 100 for 7 days. D, ceftriaxone 500 plus doxycycline 100 for 7 days. And E, I need more information. So the answer here is D, ceftriaxone 500 milligrams IM times 1 plus doxycycline 100 milligrams POBID times 7 days. This is assuming that we know the weight of the patient and that the weight is less than 150 kilograms. And so this patient has cervicitis. This is defined as, or notable for having an erythematous friable cervix with mucopurulent discharge, but can occasionally be asymptomatic. The etiology is more commonly gonorrhea or chlamydia, particularly if there are many leukocytes on wet prep, more commonly than Trichomonas or HSV2, but those are also important etiologies to consider. Oftentimes with cervicitis, no organism is identified or isolated, and cervicitis can also be due to a number of non-infectious etiologies. If cervicitis is persistent or recurrent, consider Mycoplasma genitalium as an etiology as well, and again, we'll talk more on this soon. It's important for patients with cervicitis to assess for any signs of pelvic inflammatory disease. So what is the treatment? The recommended treatment for acute cervicitis, which is the same as the treatment for acute urethritis, is ceftriaxone 500 milligrams to empirically treat for gonorrhea, and doxycycline 100 milligrams BID for 7 days to empirically treat for chlamydia. For chlamydia, an alternative treatment of azithromycin 1 gram times 1 remains, but doxycycline is the preferred treatment for non-pregnant patients. As with gonorrhea or other STIs, it's important to test for other STIs besides gonorrhea and chlamydia, including HIV and syphilis, and also to remember to check if there's pharyngeal or anal exposure and test accordingly. As before, test sexual partners within 60 days and consider expedited partner therapy. It's important to retest all patients with diagnosed gonorrhea, chlamydia, or trichomonas in 3 months, regardless of symptoms, due to high rates of reinfection for these organisms. But notably, testing before 3 weeks for chlamydia and before 1 to 2 weeks for gonorrhea could actually be false positives due to non-viable organisms from the original infection. So don't treat sooner than 3 weeks after treatment for chlamydia and sooner than 1 to 2 weeks after treatment for gonorrhea. A true test of cure is not recommended except for in the following circumstances. This includes pregnant women with chlamydia, and in that case, a test of cure is recommended 4 weeks after treatment. And then, as I mentioned before, anyone with pharyngeal gonorrhea should be tested at 7 to 14 days after treatment per the recent guideline updates. And so just to provide a few more details about pelvic inflammatory disease, as I mentioned, it's important to assess for signs of PID in women with cervicitis. Women who have recurrent infection with gonorrhea or chlamydia or have delayed treatment are at higher risk for developing PID. PID can occur due to these organisms even if testing is negative from the lower genital tract, because the upper genital tract could instead be affected. PID can also occur due to other organisms, specifically anaerobes. PID is a clinical diagnosis with a confluence of symptoms, pelvic organ or cervical motion tenderness, and white blood cells noted in the vaginal fluid. Treatment is early antibiotics is very important. This can help to prevent sequelae of PID, notably infertility or future risk of ectopic pregnancy. And the current guideline recommended outpatient treatment for PID is ceftriaxone and doxycycline, the same as I showed you in the previous slide. However, metronidazole should also be added in patients with PID, and this is a new guideline recommendation for 2021. For patients with PID, the ceftriaxone can be given as one dose, but doxycycline and metronidazole should be continued for 14 days. For complications, patients should be reassessed if they're treated as an outpatient for hospitalization needs. If a patient is pregnant, doesn't have a response to outpatient antibiotic therapy, has concerns for poor follow-up, has severe nausea or vomiting, or any concern for tubo-ovarian abscess, those patients require hospitalization. For treatment of tubo-ovarian abscess, these require antibiotic therapy, but surgery should be considered if there's progression of the TOA on antibiotics, if there's any non-resolution of the fever with antibiotics, or if there's a suspected leak or ruptured abscess. So why is doxycycline now the preferred antibiotic for chlamydia infection? So in 2022, there was a meta-analysis of 12 randomized controlled trials, and this actually showed that azithromycin and doxycycline were equivalent for chlamydia urethritis. So from the 2015 guidelines, they were both options, doxycycline and azithromycin, were listed as recommended treatments. But all of these studies had a number of limitations, and there's been subsequent literature on this topic that resulted in the guideline change. There was a randomized controlled trial that was published in 2015 of azithromycin versus doxycycline given as directly observed therapy in a correctional setting for urogenital chlamydia. In that trial, there were 5 azithromycin failures versus 0 doxycycline treatment failures. Azithromycin did not meet non-inferiority in this study, but you can see there was very high efficacy for both azithromycin and doxycycline. However, the study raised concern that there may be some risk for azithromycin failure for treatment for urogenital chlamydia. Recently, there was a study published in the New England Journal of Medicine that showed that doxycycline was superior to azithromycin for rectal chlamydia in MSM, so 97% efficacy for doxycycline versus 77% for azithromycin. And so the considerations that resulted in this change in the guidelines is first the potential for rectal chlamydia, which clearly there is a higher risk of azithromycin treatment failure, including in women. So that consideration certainly favors doxycycline. There is a consideration of adherence. Azithromycin is given as a one-time dose, whereas doxycycline is a multi-day dose. And so for patients that have notable challenges with adherence, those patients would favor treatment with azithromycin. And then going back to what I mentioned before about antibiotic stewardship, and wanting to decrease overall azithromycin use in order to preserve azithromycin for other infections, that consideration favors use of doxycycline. And these are the considerations that resulted in the change in the movement of doxycycline to preferred and azithromycin to alternative for treatment of chlamydia. Moving on to case 3. This is a 56-year-old postmenopausal woman. She presented to an emergency room in Atlanta with the skin lesions shown here on the right. She is from rural South Georgia. She is not sexually active. She reported 4 lifetime male sexual partners. She smokes cigarettes, drinks alcohol on the weekends, and does not report any other drug use. And notably, the lesions have been present for about 4 months, and she'd been seen in 2 other emergency rooms and had not had any improvement with the therapies. So which type of test confirms the diagnosis? A is skin biopsy with pathology, B, blood culture, C, blood serologic test, or D, PCR test of the skin biopsy specimen. So the answer here is C, a blood serologic test, and this is a patient with secondary syphilis. Her RPR was positive at greater than 1 to 512, and her treponemal IgG was positive. Notably, she also was diagnosed with HIV at the same visit. And so I do want to comment that this patient had somewhat atypical appearing lesions for what we typically think of as a syphilis rash. So typically we see hyperpigmented lesions that affect the palms and soles, and they can be erythematous and also be more diffuse, as shown in this image here. But I want to just point out that remember that syphilis is a imitator, and the lesions can look like this, meaning they can be more crusted or pustular in appearance. They can also look like this. So this is essentially looks like a Herald patch. It's a single plaque-like lesion that typically is seen with pityriasis, but this patient actually has secondary syphilis. And this is another patient that has secondary syphilis in the setting of late-stage AIDS, and you can see that these lesions look very psoriatic and were quite diffuse, but this patient also had secondary syphilis. So it's important to have a low threshold for any patient that comes in with skin lesions to consider syphilis in the differential diagnosis. So let's briefly review how to determine the stage of syphilis, as the staging does affect treatment in certain situations. So the first question is, are there any signs or symptoms? If yes, is the symptom a chancre or a painless ulcer that occurs at the exposure site, usually 3 to 90 days after exposure, that may spontaneously heal within 3 to 6 weeks? If that's the case, then this is primary syphilis. If the sign or symptom is more systemic, like a rash, lymphadenopathy, fevers, then those patients have secondary syphilis. If there are no symptoms, then that patient has latent syphilis. And then the next question is this early latent syphilis or late latent syphilis? In order to determine that, if the patient has any of the following in the past year, if they've had a negative syphilis serology in the past year, or a full 4-fold increase from a previous negative serology that was documented in the past year, if they had a known contact with someone with syphilis, or if the patient has a history of typical signs or symptoms of either primary or secondary syphilis, but those are now resolved, then this patient has early latent syphilis. If the answer to all these questions is no, then the patient has late latent syphilis. And so how do we diagnose syphilis? There's 2 types of tests. There are serologic tests, which can be either non-treponemal tests. These are non-specific tests like an RPR or a VDRL. They are quantitative, meaning they're titered using serial dilutions, and they decline over time. So you can monitor whether a patient has an expected 4-fold drop with treatment. The other types of tests are treponemal tests. These are specific tests against the causative organism, T. pallidum, and these are either usually EIA or CIA or TPPA or FTABS. These tests are qualitative, meaning you just get a positive or negative result. And for these, the reactivity persists. So once a patient has infection, generally these antibodies will persist, and you can't differentiate whether the infection, there's a response to treatment because there's no decline over time. There's also the ability to directly detect the organism by either dark field microscopy, shown in this image on the right, or by PCR or direct fluorescence, but none of these tests are widely available, so generally we are relying on serologic tests, treponemal and non-treponemal. Syphilis screening algorithms can be a little bit complex. There's actually 2 options, and so it's important to know which algorithm your lab is using in order to help with interpretation of results. So the traditional algorithm is to start with a non-treponemal test like an RPR, and then if this is positive, then reflex to a treponemal test for confirmation like an EIA. If this is positive, then syphilis is present, either past or present. The reverse algorithm is to start with a treponemal test first, like an EIA. If this is positive, then reflex to a non-treponemal test like an RPR. And if the RPR is positive, then syphilis is present. If the RPR is negative, then another treponemal test is recommended, like a TPPA. And so I know this is a lot of information, but the take-home point here is just to make sure that you know which algorithm you're using and consult specialist if the interpretation is confusing. I do want to point out, though, that these tests are not perfect, especially in the setting of primary syphilis or tertiary syphilis. So you can see they are excellent, all of the options that I mentioned for secondary syphilis, and they're also excellent to identify latent syphilis, but for primary syphilis, there are some infections that can be missed, particularly when using an RPR. And so if a patient has a lesion consistent with primary syphilis, then they should be treated as such, irrespective of that result. And so what does a primary syphilis lesion look like? So you can see a typical lesion from this photo. It's a shallow ulcer that is generally painless. But I do want to just keep just a note that these can occur in different locations than in the genital area. So you can see here is a primary syphilis chancre on the tongue, and here is a primary syphilis chancre on the finger. And so again, as with the secondary syphilis rash, it's important to maintain a high index of suspicion anytime there's a lesion and consider syphilis in the differential diagnosis. So it is not uncommon to get discordant results between the treponemal and non-treponemal test, or between the screening and confirmation tests. And I'm not going to go through this in detail, but I want to leave this slide for reference. If you have a positive EIA but a negative RPR, generally this is a true positive, but for one of these various reasons that are listed here, though on a rare occasion a false positive can occur. Alternatively, if the RPR is positive but the EIA is negative, this is generally a false positive, and false positives can occur due to a number of conditions that are listed here, but keep in mind that this can occur during pregnancy. What is the treatment? So primary, secondary, and early latent syphilis are treated with a single dose of benzathine penicillin injection. Alternative is doxycycline for 14 days. For late latent syphilis, the recommended treatment is 3 doses of benzathine penicillin given once weekly. It's important really for any stage of syphilis to assess for neuroocular auditory symptoms and to evaluate for neurosyphilis with a lumbar puncture if any of these symptoms are present. For treatment response, it's expected that a patient will have a 4-fold decline in the RPR titer after treatment at least 24 months, and that represents a 2 dilution change in the RPR. Non-response can occur. It's actually relatively common, 15 to 20%. It's more common in those who are older, who start with a lower baseline RPR at the time of treatment or have later stage syphilis. There are some patients that remain what's called serofast. That means that the RPR stays persistently positive even at 24 months, despite having an appropriate 4-fold decline in titer. This actually occurs in 1/3 of patients, especially those that might start at a very high RPR at the time of treatment. And so let's move on to the next case. This is case 4, a 21-year-old man who presents for evaluation of urethral discharge. He is sexually active with only men. He's been seen in the clinic 15 times over 18 months. Sometimes there's visible discharge on exam. Usually urethral gram stain is performed and there's no organisms seen, but sometimes there is quite a bit of inflammation. Each time the patient's tested for gonorrhea and chlamydia by NAT and is negative. The patient was empirically treated 4 weeks ago when he presented with the same symptoms with azithromycin. Partners were treated at that time, and at that time GC and chlamydia were negative. On physical exam, there's thick white urethral discharge, evidence of white blood cells, and no gram-negative diplococci observed on the gram stain. And so what would you treat this patient with on the day of the visit? A, azithromycin, B, doxycycline for 7 days, C, moxifloxacin for 7 days, D, metronidazole 2 grams times 1, or E, doxycycline and moxifloxacin for 7 days. So the answer here is actually E, doxycycline, followed by moxifloxacin for 7 days. This patient has persistent or recurrent urethritis. This is defined as symptoms in the presence of ongoing urethral inflammation. This can also can occur for cervicitis as well, so it doesn't need to be just urethritis. The important thing to note here is that if urethritis or cervicitis is persistent in the absence of reinfection or non-adherence of another organism, think about Mycoplasma genitalium. This is an emerging sexually transmitted infection that may not be familiar to the group because we haven't had a test for it available in the past. But there is a new FDA-approved nucleic acid amplification test, so once we're able to test for it more, we will continue to identify this pathogen more frequently. The other important thing to note is that resistance is increasing for this organism. Doxycycline now only has 30 to 40% efficacy, and azithromycin has less than 65% efficacy. Ideally, testing is using the new FDA-approved NAT, along with molecular resistance testing for macrolides, but this is really not commercially available yet. And so for treatment of Mycoplasma genitalium, in the absence of any macrolide-resistant testing, the recommended treatment is to use doxycycline 100 milligrams PO/BID for 7 days, followed by moxifloxacin 400 milligrams PO times 7 days in order to account for this increasing resistance. In addition, for a patient with persistent or recurrent urethritis, who is a man who has sex with women, which was not true for the case that I mentioned, but also lives in a high Trichomonas prevalence region like Georgia, it's recommended to also add treatment for Trichomonas with metronidazole 2 grams PO times 1. Mycoplasma genitalium has a number of associated syndromes aside from male urethritis. It can also be associated with female urethritis, cervicitis, PID, endometritis, and all of the others listed here, and we'll likely get more information about this as testing for this pathogen increases. Moving on to case 5, this is a 19-year-old female who presents with low-grade fever, malaise, vaginal pain, and dysuria. This is her cervical exam shown here. What is the diagnosis? A, vulvovaginal candidiasis, B, trichomoniasis, C, primary HSV2 infection, or D, LGV. And would your answer change if I showed you this as her external exam? So the answer here is, of course, primary HSV2 infection, which is obvious by the external exam in the presence of multiple ulcers, and you can see a lot of ulceration along the cervix as well. And so genital herpes. Genital herpes is caused by HSV, usually HSV2, although there's increasing association between HSV1 and genital herpes. HSV is very highly seroprevalent in the population. So HSV1, 50 to 60% of the population has been exposed to HSV1. For HSV2, it's about 25%. For genital herpes, the primary infection generally presents with more systemic symptoms than reactivation. This includes fever, headache, pain and itching, and tender inguinal lymphadenopathy. And primary infection can also frequently involve the cervix and urethra and have those associated symptoms. Reactivation can be milder or can be more severe, but is far more common to occur with HSV2 than with HSV1. There are some complications that can occur, including aseptic meningitis, encephalitis, transverse myelitis, and hepatitis, and these are important things to consider for patients who have symptoms in these areas. For diagnoses, the main modality of diagnosis is viral testing from the lesion using nucleic acid amplification testing or by culture. This is not a perfect test. Sometimes the patients present after the lesions are resolving or resolved, and in that setting, viral testing may be negative even if HSV is the causative, is the etiology. There are type-specific serologic tests, and these there's more information about use of these tests in the updated 2021 guidelines. but these can be useful as long as they are type specific, meaning that they can distinguish between HSV 1 and 2. And they're useful in those settings where you are suspecting genital herpes, but you can't establish the diagnosis by either culture or PCR. Treatment is with valacyclovir, famciclovir, or acyclovir. I prefer valacyclovir for patients because of its high bioavailability and less frequent dosing. This slide is here for reference, just to note that there are other causes of either painful or painless genital ulcers, and this slide can help you to distinguish between some of these causes. The one more commonly seen here in the United States is LGV, caused by Chlamydia, Trichomonas, serovars L1 through L3, and notably this can also be associated with proctocolitis. Chancroid and donovanosis is uncommon in the United States, but here's some information to help to distinguish these organisms. Case 6. This is a 24-year-old female with joint pains over the past 5 days, and these skin lesions noted below, you can see here and here. On further questioning, she's noted to have vaginal discharge for 5 days. She reports 4 male sexual partners in the last year and inconsistent condom use. Blood cultures are negative, and vaginal swab is negative for gonorrhea and chlamydia. So what is this diagnosis? So this is actually disseminated gonococcal infection. This is quite rare. It occurs in less than 0.5 to 3% of patients who have gonorrhea infection. There is increased risk in patients who either have terminal complement deficiency or are receiving anti-C5 antibody therapy or eculizumab. There are 2 possible syndromes with disseminated gonococcal infection. One is tenosynovitis with dermatitis and polyarthralgias, but without purulent arthritis, and that's likely what was present for this patient. But the second possible syndrome is purulent arthritis, which is usually monoarticular without the associated skin lesions. And so it's important to remember that those are 2 distinct possible syndromes. The organism gonorrhea can be very difficult to culture from the joint fluid or the blood or the skin. The yield is quite low for all of these sites. There is higher yield for doing nucleic acid amplification testing from all mucosal sites of exposure, such as the cervix, urethra, rectum, and throat, even if the patient doesn't have associated symptoms at these sites. It's also important to distinguish this condition from reactive arthritis, and sometimes it can be challenging to distinguish. Reactive arthritis instead occurs days to weeks after chlamydia infection. It can occur in 4 to 8% of individuals that have chlamydia infection. It causes asymmetric oligoarticular arthritis of the lower extremities that sometimes can be associated with tendinitis, dactylitis, conjunctivitis, and skin and mucous membrane lesions. And this is associated with HLA-B27. And again, some of these are overlapping syndromes, but this is distinct. It occurs after chlamydia infection, whereas DGI occurs in the setting of active gonococcal infection. So case 7, this is a 24-year-old female presenting to her outpatient provider with malodorous vaginal discharge and dysuria for 4 weeks, but without fever or abdominal pain. She's on oral contraception. She has 2 male sexual partners in the last 6 months and is not using condoms. On exam, there's some excoriations near the vaginal introitus. There's moderate frothy yellow malodorous discharge without cervical bleeding, and there's no uterine or adnexal tenderness on bimanual exam. Vaginal pH is 6.5, and on wet mount, there's numerous motile trichomonads, no clue cells, and KOH is negative. And so what is the preferred treatment for this patient and for the patient's partner? A, metronidazole 1 gram PO times 1 for both. B, metronidazole 2 grams PO times 1 for both. C, metronidazole 500 milligrams BID for 7 days for the patient and 1 gram for her partner. D, metronidazole for 7 days for the patient and 2 grams for the partner, or E, any of the above. So the answer here is D, metronidazole 500 BID for 7 days for the patient and 2 grams PO times 1 for the partner. And so this is Trichomonas infection. This is very common, and many women have minimal or no symptoms, but it is important to recognize because it can be associated with adverse pregnancy outcomes and other complications. Microscopy is sensitive, but only 60 to 70%. And so it is not perfect to diagnose infection. There is nucleic acid amplification testing, and this is highly sensitive and specific. The treatment for women, as I mentioned, this is new for 2021, is revised to multi-day dosing, so metronidazole 500 milligrams POBID for 7 days. And this is because of improved efficacy with this regimen compared to the single dosing from a recent randomized controlled trial. For men, the guidelines are still to treat with metronidazole 2 grams PO times 1, and for both men and women, tinidazole is an alternative. Treatment failure is common for Trichomonas, but there's also high rates of reinfection. So retesting is recommended at 3 months, and it's important to remember to treat sexual partners. There can be true treatment failure due to metronidazole resistance, and for these cases of treatment failure, meaning not reinfection, the treatment regimen is tinidazole or metronidazole 2 grams for 7 consecutive days. Resistance testing can be done. This is the link to obtain resistance testing through CDC, and then CDC can be consulted for recommendations based on these results. And so just to close, there are a lot of changes in the new STI treatment guidelines that I hope I've been able to cover for you in this lecture. But just to highlight these take-home points, gonorrhea treatment was modified to account for pharmacokinetic changes and resistance, and is now recommended as ceftriaxone 500 milligrams IM times 1 with a higher dose for those that have a weight greater than 150 kilograms. Chlamydia treatment guidelines also changed based on new randomized control trial data on treatment efficacy, especially for rectal chlamydia, and the preferred treatment is now doxycycline times 7 days with azithromycin as an alternative. It's important to consider Mycoplasma genitalium testing and treatment for patients, especially with persistent or recurrent urethritis or cervicitis. And the treatment when resistance testing is not available is doxycycline followed by moxifloxacin. Trichomonas treatment for women is now multi-day metronidazole, so metronidazole 500 milligrams POBID for 7 days. And of course, for more details, see the new 2021 STI treatment guidelines. If you have any questions, feel free to contact me by email, and there's some helpful resources at this website.
Thank you, Dr. Sheth. That was an amazingly timely update. For those of you who already have the CDC app in place, it is useful to the point you will refer to it most days. I'm sure there has been a recent update, as Dr. Sheth alluded to, for the 2021 update. My app updated automatically. If you already have your app in place, you might go back and check and see if it's updated. If not, maybe reload the new 2021 content. I think we had actually a comment in our chat box regarding that. Thank you, Dr. Zertucci, for pointing that out to everyone. So I expect everybody to go straight to the App Store now. And also thank you for troubleshooting each other's comments. Dr. Collins pointed out that the slides are available under our Materials tab in the app. They'll be there for the next 90 days for CME credit, and during which time you can refer, you can email to yourself, and certainly make use of that content. I think Dr. Spann had a question. Did you get that sufficiently answered, Dr. Spann, or would you like to unmute?
Yes, she answered it. She answered it.
Okay, thank you. Thank you. Dr. Royak, would you like to unmute and ask your question, or is that just a particular comment?
Well, yes, question and comment. So yes, thank you, Doctor. Excellent, timely discussion, lecture. So I see that our local health department is giving 3 doses, weekly doses of penicillin for primary syphilis during pregnancy. It doesn't seem like it's wrong based upon up to date. And then the other question is about penicillin desensitization. That's always the 500-pound elephant in the room. We have no one here at Memorial that's willing to undertake that, whether it's ID or the intensivists. Thoughts?
So I'll get to your first question. You interpreted it correctly. So the guidelines currently recommend treatment of syphilis during pregnancy based on stage. So the guidelines do recommend 1 dose of penicillin if it's primary or secondary or early latent syphilis. However, there is a paucity of data on treatment of syphilis during pregnancy. And because of concerns about pharmacokinetics changes during pregnancy, some people do recommend giving multi-dose treatment during pregnancy for any stage. There is likely little harm unless you're in a situation of penicillin shortage, which has happened in the recent past, but to my knowledge is not currently a major issue. So I do think that the practice is appropriate based on the information available in the literature. The second question regarding penicillin desensitization is a good one. It's an excellent question. It does need to be a collaborative effort between ID, allergy, and intensive care if that's what is required. I will say that for a lot of patients, taking one step back and preparing an algorithm for who truly needs desensitization is extremely helpful. And there are some recent papers that have been published where between infectious disease and allergy, there's been algorithms made based on the patient's self-reported allergy and the drug that's to be administered that actually helps to really kick a lot of patients out of requiring desensitization. I'm happy to share one of those at a later date if that's helpful. Nonetheless, you may still come across patients that need desensitization. And really the only option is to be able to hospitalize the patient in an intensive care setting for that process and then administer the dose. Sometimes involving pharmacy in this process is also extremely helpful. So I don't know if that's an option in your setting. If you have specialty pharmacists that are able to take the lead in developing those protocols and helping the subspecialists to implement.
Thank you very much. Very helpful.
I'll take a moment to comment on the app since it was raised in the chat box. So actually the 2021 app is still under development by CDC. But if you go to the STI treatment guidelines website on CDC, there's instructions on how you can temporarily flag the website itself and make it basically show up like an app on your phone temporarily until the 2021 app is available. And I would delete the 2015 app once you've done that just to avoid confusion.
That clarification, that may be what I had done, Dr. Sheth. Thank you. There is a good bit of comment in terms of your last comment regarding desensitization. I will say Dr. Span and myself, we have had better luck through use of an allergist in terms of desensitization. Dr. Collins, would you be willing to unmute yourself? I think this is an excellent question to share with everyone regarding trichomonas.
Sure. Good morning, and thank you so much. That was an excellent presentation. Regarding trichomonas, so there's been some research about transmissibility of HIV just because of how trichomonas does affect the vaginal barrier. So my question has always been, why is it not reportable, number one? Number two, if someone has a documented allergy to metronidazole or tinidazole, how do you manage that? And then number three, I have had a patient like that in the past, and I did find some research regarding the use of paromomycin, which can be compounded by a pharmacist and then used intravaginally. Does have a little bit of ulceration and bleeding associated. So just wanted to know recommendations on that utilization as well? So that's kind of a loaded question.
Yes, so so kind of similar to the penicillin situation is that I think the first step with a self-reported allergy is to truly confirm that that the allergy was an IgE mediated allergy and that it requires alternative process. Now it is important to obviously treat, but for most patients with trichomonas have relatively mild symptoms and may have alternative therapies. Probably we wouldn't pursue desensitization. Now, I have done it in the past for a pregnant patient who required metronidazole treatment for trichomonas and had a documented allergy. There are alternatives, as you mentioned. They're not well studied. They're similar to what's listed in the 2015 guidelines, and they are reiterated in the 2021 guidelines, and it involves promomycin, which has to be obtained from a compounding pharmacy and does have some side effects, as you mentioned, with ulceration, but it can be used and it is effective to treat trichomonas in patients who either have treatment failure or have allergy that's severe that doesn't allow for use of metronidazole or another like tinidazole.
And what about the reporting?
Thank you, Dr. Sheth. We've got a couple of more questions if you have time. Dr. Goldman, would you like to unmute and share your concern?
All righty. In about 2005, I guess, when the introduction of HPV testing, we really eliminated the annual screen. And we were picking up, especially on young multi-partner young women, a lot of venereal disease, also a lot of low levels of abnormal PAPs. And now we have increases in cervical carcinoma and a big increase in venereal disease. I think that that's because we're not doing annual testing. We threw out the baby with the bathwater. What do you think?
So you're talking about annual PAP testing, correct?
Yeah, as a way to get women into the office to be screened every year.
Yes. I agree with you. I think that it's important to maintain the need for an annual comprehensive well woman exam or primary care exam and visit for women, regardless of whether PAP testing is needed. I mean, really, it's true for all adults for many different conditions. Now, speculum exam may not be needed to do that, though it may be needed for other reasons. Self-collected swabs are completely appropriate for STI screening. However, you made an excellent point that you need to, the woman needs to know to come into the office once a year, and that is truly a deficiency. I will say it's a deficiency across populations for men as well. So thank you for raising that excellent point.
If I can throw this also in, prior to the HPV vaccine, the CDC said that we had 9,000 patients a year that died of cervical cancer. In my 50+ year career, I have only had 4 patients that died of cervical cancer. None of them had ever gotten a pap smear, and they were diagnosed with cervical cancer in their 40s or 50s with advanced disease. So they weren't in the system. We basically had a system that totally eliminated mortalities, and we've thrown that away for an every 3-year system doing HPV testing. I think that that was absurd.
I think it's
Dr.
a good
Goldman,
segue to the talk
we
that's
appreciate
after the
your
break
comments.
on reviewing the ASCCP guidelines. So thank you for raising that. I realized that I didn't answer the previous speaker's question regarding reporting of trichomonas. So those reportable diseases are determined at the state level by the state health departments, and then obviously to CDC for various surveillance. I can't say that I'm well equipped to comment specifically on why trichomonas is not reportable. It is very common, obviously, and does have many adverse health outcomes. And so understanding trichomonas and surveillance of trichomonas is it's extremely important, as you mentioned.
Dr. Sheth. Dr. Kaki has another question regarding treatment adherence.
Hi, Anandi. Thank you so much for this talk. It was really so great and really timely. So in response to the new recommendations that just came out, I'm actively working to update all of my clinical protocols. And as you know, a large portion of my patients are adolescents, and that directly observed therapy was our go-to. And so I'm curious about, because I'm just anticipating these questions to be coming to me more and more, is that if I have a young person who has chlamydia and she's picked up her doxy, or she has trick now and has picked up her flagell, but, you know, takes 4 days of it, or, you know, kind of stops in the middle or what have you. Is there any evidence about how much is enough, such that I wouldn't have to reinitiate a course of treatment, knowing that we're still going to, you know, aim to have that test for reinfection in 3 months? I'm just wondering if you can comment and help me figure out what my policies and protocols should be.
So it's a little bit different for chlamydia and for trichomonas, but I will say that for both, we only have RCT data that compares the one-time regimen versus the multi-day regimen. So we don't really know what happens if you take anything in between, per se. In our clinic, we do usually mention to patients for both scenarios that there is an alternative that is a one-time dose, and basically have a shared decision-making conversation with the patient about what's most appropriate. The reason for that is that I also work in a setting where patients do have adherence challenges for various different reasons. And so I do think it's important to elicit that information at the time of making the treatment decision. There are some data, however, that perhaps those adherence challenges are less than we think, or less than we may assume as providers. And so I do think it's worth rolling out as recommended by the guidelines, and then reassessing on how things are going. The retesting is also extremely important in this situation, though, because it helps to understand when there's treatment failures, as well as to communicate to patients that if they were symptomatic patients being treatment, that if they have recurrence of symptoms, that they need to come back, and to make sure to consider the preferred treatment in those settings. The last point I'll make is just consideration of rectal infection, again, especially if you're seeing individuals who may be at risk, because those may be patients to prioritize or really kind of push a little bit on taking the multi-day treatment instead of one-time treatment.
Thank you so much.
If there are no further questions, I'm going to ask one final question. As you alluded to, Dr. Sheth, self-collect is pretty much on par in terms of our results with physician collect testing. I am brand new to college health, and so this was a new concept to me, and I have been thrilled with the utilization at my particular facility. I would love to expand that to providers throughout in private practice as well. I would ask if you would mind walking through your own instructions to each patient for oral pharyngeal, vaginal, and rectal self-collect, if you would be so kind. I think that people new to this would find that very useful, if you wouldn't mind.
Sure. So actually, there's some great resources available on the last link that I put on my last slide, with posters with photos that walk patients through the self-collect for each body site, oral, rectal, and pharyngeal. And I'm happy to, I don't know if I'll have a moment, but if the chat box stays up, I can insert the link to be provided in the chat box, or circulate it at a later time. But there are a number of excellent resources that you can print out, make as posters, and review with patients that make the process easy. I will say that anecdotally for women, I think that rectal self-collection is there's some hesitation. So I think that focusing on those instructions, particularly for women, is helpful in order to gain acceptance. I do see there was another question regarding urine testing, and I didn't mention that, but it is a completely acceptable option to test for genital infection, either urethral or vaginal or cervical infection with gonorrhea or chlamydia. There is a tiny amount of increased sensitivity with vaginal samples. I think it's about 10%, but it's pretty small. So urine is completely an acceptable means to test for gonorrhea or chlamydia.
And thank you for catching that question. And yes, we'd be happy to share any sources, and the best way to do that is probably just to forward it straight to us. We'll make sure it either ends up in the chat box or on your materials page. And again, thank you, Dr. Sheth. This was wonderful. The content was great and well received, and we appreciate your gracious time in answering all our questions.